Good evening and welcome to the Barnes-Jewish Hospital Lung Transplant Program Town Hall. My name is Greg Richardson. I'm the manager of the Heart and Lung Transplant Programs. Tonight, Dr. Ramsey Hashem, our Lung Transplant Program Medical Director, will be discussing COVID-19 and answering your questions. Most of us have never experienced anything like the COVID-19 pandemic. This pandemic has impacted dramatically everyone in our country in one way or another. Tonight, we hope to provide you with some basic information about the COVID-19 virus and answer your questions about its potential impact on you and your family. We received some great questions over the course of the past several days, so thank you for sending in your questions. Please continue to submit your questions in the text box, and we'll try to address them as time permits. So let's go ahead and get started. It's my pleasure to introduce someone that most, if not all of you, already know, our medical director, Dr. Ramsey Hashem.
Thank you, Greg, for the introduction, and thank you all for joining tonight and for sending in questions. As Greg said, if you have a question that you had not already sent, please feel free to send it in during the program. And the way we're going to do this is Greg is going to read the questions, and I'll address those questions one by one. As Greg said, this is a pandemic that none of us has experienced previously, and in many ways it's turned up our world upside down with all kinds of changes, from how you go to the grocery store to how you go see the doctor and come to the doctor's office, etc. And I just wanted to start by focusing the whole program and talking in general about the impact of this pandemic. These are numbers that are very up to date, and I'm sure everyone's aware of them. They've been all over the news, and it's an ongoing tally. Worldwide, there has been 3 million cases confirmed of coronavirus infection, or COVID-19 in particular, and over 200,000 deaths as a result of COVID-19. In the U.S., the pandemic started sometime in the middle or late February and really took off in early March. In the beginning of March is when we were really beginning to get affected in the U.S. Different parts of the country have been affected at different times, as you might imagine, the country as large as ours. But thus far, 1 million cases have been confirmed in the U.S., with 56,000 deaths. In Missouri, there have been over 7,000 cases confirmed and about 300 deaths. Illinois is affected a little more severely than Missouri, with about 45,000 cases and about 2,000 deaths. So this has really affected all of us, and certainly has affected our region. And infections, and respiratory infections in particular, are a serious problem for lung transplant recipients. So we thought that this was very important to have this town hall and address questions that you all may have about how this pandemic affects you, what you can do to protect yourself, and answer those questions. And so with that introduction, let's start out with the first question, Greg.
So our first question is just about the situation here locally at Barnes-Jewish Hospital, and whether or not we have any COVID-19 patients here, and whether or not the St. Louis area is still seeing general spread of the virus.
Yeah, that's a good question. St. Louis City and St. Louis County have had a number of cases, and on a daily basis, this is being monitored with a fairly consistent number of daily new cases over the past couple of weeks. In many ways, everyone has heard about flattening the curve, and I think nationally and in St. Louis and Missouri, we have flattened the curve. What that means is that the system is not overwhelmed with a large number of critically ill patients where resources become stretched too thin and it becomes very difficult to care for those patients. Now, at Barnes-Jewish Hospital, there are a number of patients that have COVID-19 and a number of patients that have been diagnosed with COVID-19 and were either not admitted to the hospital because they didn't have severe enough illness and they went home and stayed at home, or patients that stayed in the hospital for a number of days and then have since been discharged home. And as you might imagine, the course here in St. Louis and in Barnes-Jewish Hospital in particular has been very similar to what's been seen around the world, with some cases not being terribly severe, others being sort of mild to moderate cases, and in some cases the illness has been very severe, resulting in critical illness, requiring life support, intensive care unit stay, and so on. Now, fortunately, for some reason, and this reason is not entirely clear right now, transplant patients have not been as affected as we were concerned early on in the onset of the pandemic. And what I mean by that is that the number of transplant patients that have been that have come down with COVID-19 or have had COVID-19 confirmed has been relatively small. And that was surprising and has been surprising, and yet that's been the experience across the country, and even in hotbed areas such as northern Italy and China, and in New York City, which has been an epicenter for COVID-19 in the U.S. Now, when transplant patients have developed COVID-19, they've had a wide spectrum of disease severity, from being moderately ill, where it's kind of like another respiratory virus that doesn't always require hospitalization, to being more severely affected, where they need to be admitted to the hospital. And in some cases, patients have been critically ill as a result. Now, fortunately, at Barnes-Jewish Hospital, we've not had lung transplant patients become critically ill, needing to be in the intensive care unit as a result of COVID-19.
So we received a number of questions about, coming to the hospital for appointments. Understandably, people are concerned about the safety of coming to the hospital where there are, patients who have COVID-19. So can you speak a little bit about the steps that are being taken to try and ensure patient safety, and specifically when coming for clinical appointments? So not only in the clinic, but in the pulmonary function lab and other areas where they're gonna be seen by yourself and other providers.
Yeah, that's a very good question, and it's important to relay this message that safety is something that's very important for everyone at Barnes-Jewish Hospital and the lung transplant program in particular, to be sure. First, patients that are hospitalized with COVID-19 are put in hospital units or hospital divisions that are solely for COVID-19 patients. In other words, we're segregating those that have COVID-19 from admissions to the hospital for other indications. The idea being to try to keep from having someone who doesn't have COVID-19 be exposed to other patients who have it and prevent them from getting sick. That's the situation in the hospital for hospitalized patients. Now, in terms of patients coming for outpatient visits, everybody is being screened before their visit for any symptoms. And some of the patients that have come to clinic in the past few weeks have received a phone call with a screening questionnaire, whether you've had any symptoms suspicious for COVID-19. And in cases where there are symptoms that are suspicious for the virus infection, we're asking that the patient not come to the medical center for care, but to get tested in one of the community testing centers before you come for the visit. And that's in large part to try to prevent someone who is sick from coming to the medical center and potentially exposing others to the virus. Aside from the pre-visit screening, when patients come, they're again screened for symptoms of COVID-19 and their temperature is taken to try to identify someone who might be infected. Beyond that, everybody is asked to wear a mask, and the advice aside from that is everybody should wash their hands, stay at least 6 feet apart, and healthcare providers follow the same guidelines or the same rules in terms of wearing masks. If you've come to clinic in the past few weeks, you've seen us wearing masks in clinic, washing our hands frequently, and that's all to prevent the spread of the virus.
So we have another clinic-related question, and this one is wanting to know if, when you come to clinic, if you can have someone come with you to your appointment.
Yes, we're limiting exposure in the campus, but one visitor coming with you to clinic is acceptable. Now, in the hospital, we're restricting all visitation, where patients admitted to the hospital will not be able to have visitors during this time.
So our next question is still about follow-up visits and such, but this one is more geared toward follow-up lab testing. And the question is whether or not it would be better to have a home health agency come in and have the labs drawn versus going to a hospital. And then the second part of this question has to do with just the follow-up and how long someone can safely go between appointments. This question has come up several times, and with people saying it's been between 4 and 7 weeks since their last appointment, and is that safe?
Yeah, those are very good questions. My answer tonight may be different than an answer that I would have given in the middle of March. It probably will be different than an answer that I would have given in the middle of March. And in large part, that's because what we've learned about the virus and about the spread of the virus over the past 6 weeks or so. What seems to be happening is that this is not going away anytime soon, unfortunately. Now, we've been able to flatten the curve, meaning we didn't have a massive surge of very sick patients that require hospitalization over a short period of time, and that's been terrific because that would have been a very critical situation. On the other hand, the number of new cases seems to be the same over the past several weeks, and it really seems to be that the virus is not disappearing soon enough. Now, we all want it to go away. We all want it to go away tomorrow and not come back, but the reality is that it's lingering and hanging on. Now, the way that pertains to the question is, if this was going to be a short-lasting pandemic for, let's say, 2, 3, maybe 4 weeks, it would be fairly reasonable to say, well, look, this may only last three or 4 weeks. We can postpone any testing that that you would ordinarily have had until this is over. And once this is behind us, you can get your tests again, and we won't have anything to worry about. But since this is going on longer than anyone wants, I think we have to be cognizant of other health problems that need medical attention, like taking your immunosuppression medications. Are you on the right doses? Are you on too much, too little? And the only way to follow that is with lab testing. And so as more and more time passes, the need for labs becomes more and more necessary, and it becomes harder to sort of put that off. So back to what I initially said, in middle of March, I would have said, don't worry about getting your labs drawn. Let's push that off a few weeks or so. But here we are 6 weeks into it with really no clear end in sight. We really need to make sure we're getting the right labs done, the pulmonary function tests done, and so on. Now, to answer the specific question about home health versus coming to a lab to get the labs drawn, obviously, if we can arrange a home health visit and that can be covered and we can get the testing that's necessary, that would be safer because a nurse would come to your house, draw the blood from a port, and you're only exposed to one person who's going to use protection, etc. as opposed to coming to a lab where you might have to wait in a waiting room and be exposed to other patients and you don't know what they have, etc. Now, in terms of how long can go in between tests, that's really dependent on the situation. And so I hate to make a blanket statement that everybody should get labs, pulmonary function tests with a certain frequency. Only after transplant, as everybody is aware, we get testing done much more frequently than at later time points after the transplant. And that's because you're getting used to the medications. The medications are fluctuating in your system. We're making a lot more adjustments in the early period than after, say, a year or after 2 to 3 years. And at those time points, we're getting testing done less frequently because you've sort of stabilized with your medications and we've got the right doses, reaching the right levels, and so on. So I would say that if there are any questions about when is the right time to get testing, or has it been too long in between my tests, when should I get my follow-up tests done, I would address those questions directly with your nurse coordinator, who's going to speak to the physician and decide what's appropriate for any individual patient.
So continuing on the topic of clinic appointments, we had several people asking about appointments that are currently scheduled to take place in May or June, and wanting to know if they should keep those appointments or reschedule them.
Yeah, I think that should also be an individual case-by-case basis. We postponed a lot of appointments in the middle of March going into April, and I think that was the right thing to do at the time. But as more time passes and the previous appointment may be too far in the past now, again, I think the best approach is to reach out to your coordinator, who may already be planning to reach out to you, and discuss what's the best time to schedule a return appointment, whether it should be in June or early May or middle of May, depending on the scenario that's going on, what's been going on, how you've been feeling, whether you've had any illnesses. And so it's best as a case-by-case scenario.
And then our final clinic appointment-related question is regarding telemedicine or telehealth appointments, and what your thoughts are on patients who may be able to have a telehealth visit with their local pulmonologist.
Yeah, I think that those are helpful. As you know from all of your previous experiences, when you come to the lung center for clinic visits with us, or your previous appointments with your pulmonologist, one of the most important tests is pulmonary function tests, particularly beyond the first 6 months or year after the transplant. And that's really the best way that we monitor your lung function and monitor whether there are signs for rejection and so on. And so with a televisit or a telehealth visit, your local pulmonologist won't be able to do pulmonary function tests, and so we're hampered without pulmonary function tests. Now, what can take the place of pulmonary function tests in a pulmonary function lab is the microspirometer that many patients had early after transplant. And that can be a tool right now when pulmonary function tests. Some patients, it's a useful way to function. I'm having some background noise. I'm sorry. I'm not sure what's causing that.
Our next question is about the current CDC guidelines recommending that high-risk individuals self-isolate until regional hospitalizations decline for 6 weeks. And then there's kind of a second part to that of whether or not you see forthcoming changes in CDC guidance.
Well, based on previous experience over the last 6 weeks, I think everything has changed multiple times. Sometimes it seems like something changes over the span of a day. So I don't think that anything is going to be written in stone anytime soon. And I don't fault anyone for this. I say this jokingly, but we've learned so much about this virus and the spread of the virus and its impact over the last 6 weeks. So I recognize the difficulties that the CDC has been under, but I think that guidance is well-founded. Patients that are at increased risk for serious complications related to COVID-19 include transplant patients. There are other categories of patients who will be at increased risk, and so I think that anyone who is at increased risk for some serious complication should be even more careful and extra vigilant. Now, in many ways, the good news is that transplant patients have been practicing social distancing for a long time. Masks are nothing new for transplant patients, particularly lung transplant patients. Hand sanitizers are nothing new for transplant patients. And so in many ways, transplant patients are professionals at being careful and preventing infection and preventing picking up infections. But this is exactly the time to be even more vigilant in those infection prevention measures.
Our next question asks what patients should do if a family member tests positive or has symptoms for COVID-19.
Yeah, that's a very good question, and it's a challenging question depending on the circumstances. But if your spouse tests positive for COVID-19 and you're still asymptomatic, it's really important that you separate from your spouse for at least a period of 2 weeks, and you want your spouse to be asymptomatic for at least a 2-week period before you come back in close contact with them. Now, saying that is much easier than actually doing it. How can you separate from your spouse? You live in the same house. But to the extent that it's possible, that would be certainly advisable. Whether your spouse can go stay with a relative or whether you stay with a relative that's unaffected, that sort of isolation is really important. Now, if you develop symptoms, and this is probably going to be one of the upcoming questions if it hasn't come through yet, if you develop symptoms, you should call the transplant coordinator or your local physician if you're not in this area to figure out the best way and the easiest way to get tested and whether you should be admitted to the hospital. The decision to admit to the hospital is really dependent on the severity of the symptoms that you may have. But if you're asymptomatic, we're generally not testing patients. It's not encouraged to test people that are asymptomatic. Generally, those tests are going to be negative. But if you have symptoms that are consistent with COVID-19, we should test to see if that's the case. And there's a variety of options depending on the symptoms that you have and the severity of those symptoms.
There's been a lot of talk in the news about testing for antibodies, and we've received a number of questions wanting to know if we're going to be testing for COVID antibodies and if the people have contracted COVID-19 and what their immune system would react like versus other patients who may not be immunosuppressed.
Yeah, that is a very good question, and there are multiple levels of that question. We're currently not testing for COVID-19 through a blood test or an antibody test at Barnes-Jewish Hospital. There is an antibody test that is being used elsewhere, but we're using the nasopharyngeal swab to test for COVID-19. There was a recent publication from Northern California where a large number of individuals who had not been symptomatic were tested with blood tests. And many of those individuals who had never had symptoms that were recognized as COVID-19 had antibodies to the virus, suggesting that in many cases the virus causes a mild illness among people who don't have any predisposition for more severe illness. Someone who's healthy, hasn't had a transplant, hasn't had any medical problems. Now, again, that antibody test is not currently used at Barnes-Jewish Hospital to diagnose people with COVID-19. Whether that changes or not, I'm not sure. I would not be surprised if that test becomes available and we begin to use it. Now, the second part of the question is, how does the immune system of a transplant patient respond to COVID-19? And that's a fantastic question. The answer to that is we don't know yet. And we don't know yet mainly because the virus has been around for a brief period of time. Now, we are planning a research study of all organ transplant recipients, so not only lung recipients, but other organ recipients who develop COVID-19 to see what happens to them clinically, and also collect blood tests on these patients to see what the immune response to the virus is during the acute phase of the illness, and also over time after you recover from the illness, to better define what that immune response is. But it's very likely that the immune response of a transplant patient will be different from the immune response of an immunocompetent patient or a patient who has not had a transplant because of the anti-rejection medications.
Along those same lines, can you speak a little bit about the potential use of convalescent antibodies and if you see a role for those in treatment of COVID-19?
Yes. Treatment with convalescent serum is something that's been around for a very long time, and that predates antibiotics and antiviral treatments. The idea is that someone gets the infection, they recover from the infection, and as they've recovered from the infection, they've developed an immunity to the infection. And that treatment, convalescent serum, capitalizes on the patient who had the infection and has since recovered, having developed an immunity to the infection, where they donate plasma, just like they would donate blood, and their plasma is infused in patients that have the infection currently. There are protocols that are FDA approved currently for using convalescent plasma for patients that have coronavirus infection. And so those are available. Obviously, the plasma is obtained from the donor at the right time after the infection. In other words, we would want to make sure that the person that's donating the plasma truly had COVID-19 and that they completely recovered from the infection and have recovered for a period of time before collecting their plasma, and also that they have an antibody response that is specific to the COVID-19 virus to derive the benefit of using that convalescent plasma in someone who's acutely ill from the infection.
We received several questions about the possibility of a vaccine being developed, and people are wondering what your thoughts are on the possibility of a vaccine coming out, and if a vaccine comes out, whether or not it'll be a live vaccine or something that would be safe for our transplant patients.
Yeah, that's a very good question. I think that vaccination will be one of the paths out of this pandemic. It's not likely that a vaccine will be available in the next few months. It takes a longer period of time to develop a vaccine and test it. Now, I suspect that a vaccine will be initially available in clinical trials to demonstrate some efficacy. So it is conceivable that in the next 6, maybe 9 months, a vaccine might be available. That would be the fastest turnaround to developing a vaccine. Now, whether that vaccine would be a live attenuated virus or a dead virus remains to be seen, in all honesty. And we'll have to see, depending on the characteristics of the vaccine, whether it would be safe to use in transplant patients. As everyone is aware, in general, live attenuated virus vaccines are not given to transplant patients because of the theoretical risk of developing an infection, although the virus is attenuated, so it's not a dead virus. Now, my suspicion is that if a vaccine is developed, it would be from a dead virus or using parts of the virus that cannot replicate and cannot cause an infection in people that get the vaccine. But we don't know yet what vaccine might become available. And in truth, we don't know for sure that a vaccine will become available that will be effective.
Dr. Hashem, can you talk a little bit about other coronavirus type infections and whether or not having been infected with a coronavirus other than COVID-19 provides any protection against COVID-19?
Yeah, that's a very good question. Like all of the other questions, these have been really terrific questions. There are multiple other coronaviruses that have been around for many years. This current coronavirus is different. Originally, it was called novel coronavirus 2019 because it was different from these other coronaviruses. And some of you may know these other coronaviruses as HKU1. The HK was for Hong Kong. That's where it was originally discovered. There's an OC43, there's an NL229. Those are viruses that cause respiratory illnesses that are much more mild than what we're seeing with SARS-CoV-2. That's the name for the virus that's causing COVID-19. And this virus that's causing COVID-19 is more similar to the coronavirus that caused the original SARS outbreak in 2003 in China and in Canada, and closer to the coronavirus that caused the MERS outbreak that I think is still ongoing in the Middle East. Those viruses are different from these other viruses, the HKU and NL63, et cetera, in that they're a lot more pathogenic and a lot more virulent and a lot more contagious. So they're much worse. It's easier to get them, and if you do get them, they're a lot more likely to make you much sicker than these other coronaviruses. But having had one of the other coronavirus infections does not protect you from this current coronavirus infection.
So there have been reports in the news about recommending that people boost their immune system. And so one of our patients is asking, should transplant patients do something in an attempt to try and boost their immune system, or is that something that should be avoided?
I would say that that's something that should be avoided. There's always a balance between taking enough anti-rejection immune suppression medications to prevent rejection, and at the same time not getting so much immune suppression that you're sick with an infection. And in these uncertain times, I can understand the motivation to boost the immune system to fight off an infection, but I would say that the risk of rejection is higher than the risk of getting coronavirus infection, especially if one was to start to manipulate the immune system like this. Now, in certain circumstances, when lung transplant patients have had COVID-19, we have changed their maintenance immunosuppression medications in an attempt to have an antiviral immune response to help limit the virus infection. But for someone who has not had the infection or doesn't have any symptoms, I don't think it's a good idea to do something to boost the immune system.
So recently there have been some reports of COVID-19 being detected in pets. So can you comment on what you think the risk is of transmission from a family pet to one of our patients?
That's a good question. I don't know the answer to that. I don't know how often pets are getting COVID-19. And I'm not sure that anyone knows that estimate carefully. I think that it's a very uncommon event. And as a result, I don't think that it's the way that anyone's going to pick up COVID-19. You're a lot more likely to get it from the grocery store, from a relative, than you are to get it from your dog or your cat. There are coronaviruses that dogs can get. They're different from this coronavirus. There's a coronavirus that causes a respiratory illness in dogs, and one that causes a gastroenteritis also in dogs, and there are vaccines for those. But those are different from this coronavirus or from COVID-19.
So we had a number of patients asking what they should do if they think they have or have been exposed to COVID-19, and then what the treatment might look like. Would they be immediately admitted to the hospital if they test positive for COVID-19?
No, not necessarily. If you have symptoms or you've been exposed, call your coordinator for more specific instructions about your case in particular. If you test positive, it doesn't necessarily mean that you should be admitted to the hospital for inpatient treatment. In fact, if you test positive but your illness is not severe and you have a flu-like illness and you're managing okay at home and don't have much respiratory symptoms like shortness of breath, low oxygen level, you're not having terrible diarrhea, those kinds of symptoms, it's best to stay at home and self-quarantine at home and check in regularly with your nurse coordinator to see how you're doing and update us on your symptoms. On the other hand, if the symptoms are more severe, then hospitalization is the appropriate thing to do. In the patients that have been hospitalized, our first-line treatment has been to de-escalate immune suppression and typically stopping medications like azathioprine or Imuran or mycophenolate or Celsep in a way to prevent the low white blood cell count that is sometimes seen when patients have COVID-19 infection. Now, as everyone is aware, there are multiple treatments that are specific to coronavirus or COVID-19, from hydroxychloroquine and azithromycin, or one or the other, or a combination of both of those, to other antiviral medications like a medication called remdesivir, which was originally developed for treatment for Ebola, but has activity against coronavirus, and other antiviral treatments. In general, I would say that none of these treatments has been shown to be very effective, and yet in certain cases that may be the appropriate treatment. And so I wouldn't make a general statement that if you test positive for COVID-19, this is the treatment and everyone should get this treatment, mainly because we've not seen a treatment be so effective. But that may be the appropriate treatment in a specific case.
So what recommendations do you have about checkups or routine appointments with the dentist in dental cleaning and dental exams, and whether or not our patients should keep those appointments or postpone them till later?
I would say that routine dental appointments should be postponed. If there is something more urgent, then I think it would be okay to go to see the dentist, but routine dental cleaning or a 6-month exam, that's best postponed right now. I don't know how long to postpone those, but probably at least the next month or two. There's really no urgency for a routine cleaning or a 6-month dental exam. Now, on the other hand, if you're having more serious problems and need a cap or need a filling or having a lot of toothache or have a tooth abscess, those would require attention sooner, and I would postpone those visits.
So we received a question during the call this evening asking about the impact of COVID-19 on transplant, and specifically how you see this impacting the future of lung transplantation.
Yeah, it has had a big impact on the immediate future of lung transplantation, never mind the long term. the number of transplants that are being performed across the country has decreased significantly over the past 6 weeks or so. And there are a lot of factors that go into that, from concerns about whether the donor might have COVID-19 and might have died of unrelated causes. Some of those concerns have been relieved in recent weeks when testing for donors has become more widely available, and we can test donors for COVID and make sure that they don't have COVID. So that's been an improvement. There was a lot of concern about physicians and surgeons going to other hospitals to retrieve organs from a donor, to bring the organs back to a transplant hospital, and whether they might get coronavirus either en route or at the other hospital in another city. And so that's really impacted the number of transplants. As you might imagine, in places across the country that have been affected more severely than we have in St. Louis, for example, in New York City, the number of transplants decreased substantially, primarily because there was such an acute need for healthcare resources in the city and in the transplant hospitals that they were unable to do transplants. And many people, donors included, were testing positive for coronavirus. Chicago is not nearly as severely affected as New York City was a few weeks ago, but there are a lot more cases of COVID-19 in Chicago than there are in St. Louis. And so they've been affected even more severely than we have been in St. Louis.
So we received a couple of questions from patients who live some distance away, and so their trips to St. Louis for follow-up would typically involve an overnight stay in a hotel, and they're wanting to know whether or not it's safe to even stay in a hotel right now.
Yeah, that's a good question. Hotels are taking precautions, as you might imagine, but in all honesty, I don't know what any hotel is doing in particular to clean their rooms and make sure that after one person's spent the night in a room, what are they doing about cleaning the rooms for the next hotel guest? So I would say it's best to avoid hotel visits if you can. Now, if it's not feasible to avoid a hotel visit, I think that that may be necessary and you have to do it. Now, that really depends on how urgent or how necessary a visit is to St. Louis when you live some distance away. In certain circumstances, that's really what's necessary because there's a serious problem that requires attention here in St. Louis, and maybe you need to have a bronchoscopy, or maybe you need to have something else that can only be done here. If possible, I would avoid spending the night in a hotel, but I think if you have to, it's okay. I would bring some disinfectant wipes and wipe down the surface areas that you would contact, doorknobs and the like.
So we're beginning to hear more and more about plans to begin lifting some of the restrictions that are in place. And so we've received a number of questions about returning to work and whether or not it's safe for patients to return to work.
Yeah, that's a very good question. And in Missouri, the governor announced that on May the 4th, we will begin a phased reopening. I don't know the details of what businesses will reopen, but the idea is that more and more businesses will be reopening this coming Monday, a week from today. And by the end of the month, more and more businesses would reopen. So it's a phased approach. Now, whether St. Louis City and St. Louis County follow suit with those guidelines, I'm not sure. We'll have to see. This really is important for our patients in a number of ways. First, in going to these businesses, I would avoid crowds at all costs if you can. I wouldn't go to restaurants right now. I would avoid that kind of environment. Now, I think the stipulation is that in opening businesses still have to abide by social distancing, with people being 6 feet apart, and limit the number of people that go into the business at any one time, depending on the physical size of the business or the structure. Now, in terms of returning to work, it really depends on the work that you do. If it's feasible to continue to work from home or to work from home, I think that is safer than working in an environment where you're in contact with a lot of people. A number of businesses have taken very good precautions. Just as an example, at the grocery store, they have a plexiglass screen that separates the cashier from the customer, and the cashier is sort of almost enclosed entirely in this plexiglass device. And I think businesses across the country have become more and more creative in conducting their business in a safe way for their employees and for their customers. And so my advice to transplant recipients is that you want to be as careful as you can be. If you're an employee, first, if you can work from home, by all means, that's the safest approach. And if for some reason that's not possible and you have to be on the job, take all the precautions that you can, whether it's working in an environment that is not exposed to as many people, or a shift that's not as exposed to as many people. Wash your hands frequently, wear a mask. A hospital-grade mask is better than a cloth mask. Those kinds of precautions.
So our next question is also related to lifting of restrictions and a return to more normal. And the question is, should family members of lung transplant patients be more cautious about going back out into public once the stay-at-home orders are lifted?
Yes, I would advise family members, particularly household family members, to remain vigilant and remain careful, because obviously what we all worry about is if your spouse goes out, picks up the virus, and they come back home, it's likely that when they get sick, they're going to transmit the virus to you. So we would want to avoid that to the extent that it's possible. So I would caution household family members to remain very vigilant as the shelter-in-place rules are scaled back.
So we talked a little bit about the steps the hospital has taken in terms of separating patients who are known to have COVID-19. So we have a question about transplant patients who may be hospitalized with COVID-19 and whether or not our transplant physicians would still be taking care of them.
Yes, that's a very good question. What we've done is really a case-by-case scenario. Patients that are admitted to the nursing divisions that are for COVID patients only, there are two categories. There's an intensive care unit that is for patients with COVID-19, and a general nursing division for patients with COVID-19, depending on the severity of the illness. If they're in the intensive care unit, the ICU doctors taking care of the patients are generally pulmonary and critical care physicians. Some of them are transplant physicians who have sort of stepped away from transplant to provide care for patients with COVID-19. We've tried to separate those physicians from our group who are caring for patients with COVID-19 from those who are caring for transplant patients, with reasoning being to be extra cautious to avoid a physician getting the virus from a patient with COVID-19 and passing it on to a transplant patient. Now, patients with COVID-19 who are admitted to the general nursing division are cared for by a hospitalist, and at a very minimum, the transplant doctor will oversee what's happening in terms of the patient's condition. Look at the blood work, look at the medications, make decisions about the transplant medications, talk to the hospitalist about the day-to-day activities, and in certain circumstances, see the patient directly. We try to minimize exposure to COVID-19 so that those physicians don't get the virus and then transmit it to another transplant patient. But in some circumstances, the transplant doctor is seeing a transplant patient who has COVID-19.
So we have a question about the seriousness of COVID-19 and how an infection with COVID-19 compares to that of other viruses or influenza.
Yeah, that's a very good question, and that's been all over the lay media and the internet. Is this more severe than the flu? Is it less severe than the flu? It's just the flu, etc. And the answer is that it's highly variable from person to person. There have been a lot of patients who have developed COVID-19. I don't mean transplant patients, but patients in general. And the illness is mild or moderate in severity. Not terribly different from an influenza-like illness, where you feel poorly for 4 or 5 days, have fever for that period of time, and then the illness gets better and there's recovery and you return to normal. Having said that, there are a lot of people who've gotten very sick with COVID-19, have developed respiratory failure, needed life support, have been in the intensive care unit. And as everybody knows, and as I said in the statistics at the beginning, there are over 50,000 deaths in the United States from COVID-19. So it can be a fatal infection. It doesn't mean that it will be fatal, and I certainly would not take that message away that if a transplant patient was to get COVID-19, it's likely to be fatal. I would not say that to be sure, but it can be fatal, so it's a very serious infection. Having said that, influenza also causes a number of deaths in the United States. It's estimated that influenza causes somewhere around 30 to 60,000 deaths annually in the United States. So influenza can also be a severe infection. So to answer the question, COVID-19 can really span a spectrum of severity from a mild illness in some patients to being more severe in others to being very critical in a minority of patients who need life support and critical care.
So some of our patients are asking about spouses or other family members who may be considered essential workers, including family that are in the healthcare profession, and wanting to know if they should be taking extra precautions when visiting, or if they should even be visiting with those family members right now.
Yeah, that's a very good question. I would say that if you have a family member who is in the healthcare field, a nurse, doctor, respiratory therapist, and they're working in the hospital or in a clinic and may get exposed to COVID-19, it's best not to visit them for the near future because they can acquire the infection and pass the infection on before they develop symptoms. And that's that asymptomatic infection. It's not that people will not ever have symptoms necessarily, but there's a period of a few days up to potentially 5 or 6 days where they have the infection, they can transmit it, but they haven't developed symptoms yet. So I would advise distancing yourself from family members who are healthcare providers.
We have a question asking if there are any estimates for when Barnes or other hospitals will resume elective surgical procedures.
That's a good question. I don't have an answer to that, and this is being carefully looked at, I think, on a regular basis by leadership in the hospital and the medical center, and they're looking at the number of new cases in St. Louis City, St. Louis County, and in our region, and will likely make a decision based on those variables and those factors. But as of today, a date has not been announced.
So we're getting close to the end of our time here this evening. So one of our final questions here is about what is known about the risk of, or increased risk of rejection that may be associated with a COVID-19 infection?
Yeah, that's an excellent question, and on all honesty, really nothing is known about this. What we do know is that respiratory viruses like RSV, metapneumovirus, parainfluenza virus, influenza, can trigger the development of chronic rejection in the after the acute phase of the illness. In other words, someone can get sick with one of those respiratory viruses, recover from that acute illness, and in the 6 months afterwards may develop chronic rejection. How that happens is that the virus infects the airway lining cells, and when that happens, that really triggers an immune response that results in chronic rejection. Now, not everyone that develops one of those infections will go on to develop chronic rejection. How COVID-19 affects the risk of rejection is not known to date, but it is likely to be similar to these other respiratory viral infections, that it likely increases the risk of developing chronic rejection in the months afterwards. But we don't know that yet.
Well, thank you, Dr. Hashim. So we've about run out of time tonight, but really appreciate all of you attending and participating in our town hall meeting, and we hope this has been helpful in helping you learn how to best keep yourself healthy during this pandemic. We want to remind everybody that this town hall this evening has been recorded and will be available in the resources section of our website later this week. Thank you all again for joining us, and have a wonderful evening.
Thank you all.